Welcome to today's episode of Oncology Data Advisor. Today we have another interview from the ASH annual meeting for you, and I have the pleasure of being joined by Dr. Matthew Cortese, who is here to tell us more about the abstract he presented, titled Multiomic Evaluation of Immunologic Changes in Chronic Lymphocytic Leukemia with Venetoclax Treatment. Dr. Cortese, thanks so much for coming on the show today.
Thank you so much for having me. My name is Matt Cortese. I'm an assistant professor of oncology and lymphoma and CLL specialist at Roswell Park here in Buffalo, New York, USA. And thanks for having me on.
Absolutely. Looking forward to hearing more about your presentation today. So to start off, would you like to provide us with some background on CLL, particularly its immunosuppressive effects and the role of venetoclax in enhancing T cell function?
It'd be my pleasure. So CLL, or chronic lymphocytic leukemia, is the most common form of leukemia in the westernized world, and including the United States. This is typically a slow-growing proliferation of B cells, and I actually like to consider this also a disorder of T cells as well as immunocompromise with other immune cells. And in part, this is driven by the progression of CLL itself, actually. So CLL cells, we know, will exert these immunosuppressive effects through cytokine profiles by inhibiting T cell engagement and actually macrophage polarization. The whole kind of milieu with CLL is very complicated, to be honest. It's partly understood in some ways very well, in other ways almost not at all. And so we wanted to look at not only that immune microenvironments in a very high precision kind of complicated way, multiomic model, which we'll talk about, I'm sure. We also had a hypothesis that venetoclax, based on some preclinical model from Dr. Hernandez Eliza Latourie here at Roswell Park, and with some other experiments along the way over the last several years, we think that venetoclax actually has other effects on immune cells, and particularly T cells. We were most interested in our study. And we wanted to really see, what changes in CLL with venetoclax treatment in a very in-depth kind of holistic multiomic model. And then we also wanted to see, what are some of the actual drug effects on some of these other immune cells that kind of get forgotten, right? We oftentimes will look at, on-target effects on tumor cells only with, molecular investigation. We look at resistance mutations, right? But we tend to forget that these drugs are in the systemic circulation. They go throughout the body, and they have other effects on other cell types. And we wanted to actually focus on some of those kind of forgotten other cell types in the immune system. And for us, it's really germane, really important, because in CLL, CAR T cell therapy or chimeric antigen receptor T cell therapies and other immunotherapies, things like bispecific antibody therapies, which are all, we now have one FDA approval after about 11 years of research in CLL with CAR T specifically. Bispecifics are not approved yet. Their response rates are kind of mixed overall. So the importance of the immune system in CLL is critical for treating patients more effectively, right? Eventually, we hope, at the end of this road, after maybe a decade or more of research, and we'll talk about some of this, but we hope that this might lead to eventual cures for some of these chronic blood cancers. Leveraging our knowledge of the immune system to kind of finish off residual or senescent disease. But long story short, we wanted to see, what are some of the off-target effects of venetoclax on the immune system, with an angle toward treatment implications and also minimizing other complications of that immune paresis or immune dysfunction from CLL. So things like secondary cancers, secondary infections. Fortunately nowadays with our targeted therapies and our supportive care and medicines and antibiotics and intravenous immune globulins and things like that to help people through treatment. Most patients with CLL will actually eventually die of actually old age or secondary cancers or infections as opposed to the disease itself. And so it's really, really important as we get better at treating these cancers to improve immune function along the way, or at least pay attention.
Absolutely. That's a really great background. So thank you so much for explaining all of that.
My
Could I
pleasure.
talk a bit about what the main questions you aim to address in the study, as well as the design and how it was conducted?
Absolutely. So we know that killing CLL itself, with venetoclax, will repair the immune system. And so our design actually was to do some complicated bioinformatics, basically, to look at the impact of treatments and actually response to treatment. So we actually looked at things like the delta or change in the absolute lymphocyte count, changes in tumor bulk, We looked at prior treatment effects. So, if patients were treated with CD20 therapy, for example, as a debulking regimen like obinutuzumab, rituximab, et cetera, we included those patients, but we also accounted for those treatment effects in our model. And so we really are trying to tease apart, what are the effects of the drug itself, if possible, in this kind of bioinformatic analysis. And so all we did actually, though, is take blood samples from patients at baseline, basically within 24 hours prior to their first dose of Venetoclax. And then 30 days later, plus or minus a couple days, basically, we then took another blood sample from them, just an extra 3 tubes of blood, basically, not very much, IRB approved protocol. And what we did was we looked at basically RNA sequencing, and this was in PBMCs from essentially whole blood, but just PBMCs, RNA sequencing. We did RRBS, which is a methylation or methylomic study, epigenomic related investigation, and then we also did advanced flow cytometry, getting at the kind of a simplistic way of doing proteomics and phenomics, we call that, right? So what are the expression level changes on those cells? What are those cell populations doing, and how are they changing? And then we also looked at metabolomics as well. And so, Dr. Spencer Rosario here, Dr. Daekyun Kim, at Roswell, we've been blessed, and Jacob Wright, who's not even a doctor yet, but he should be very soon as a PhD candidate. Corey Mavis, Taylor Mandeville, and Dr. Hernandez, all of us worked really hard together. Basically, and obviously all of our core facilities at Roswell Park. It's my shameless plug that this is all done in-house. Basically, we were able to synthesize all these layers of information together and presented at ASH, actually, with some of our findings and some of the pathways and changes that we observed. So then lastly, I'm talking a lot, but we also built CAR T cells, actually, at both the baseline and the day 30 specimen. These were, axi-cell-like, basically CD28 co-stimulatory domain, CD28 zeta, CD19-directed autologous CAR T cells. And we used ex vivo T cells, basically, so from the body and then to the bench, used those T cells that were pre and post Venetoclax exposure, and we saw how effective they were at killing known lymphoma cell lines, and particularly Raji cells in the lab. And that's how we did it, basically.
Amazing. Thanks so much for telling us all about the study. So what were the results the study produced that you presented at ASH?
First of all, complicated. It was hard to talk about multiomics in depth. It's supposed to be 10 minutes or less. I think I spent like 13 or 14 minutes. And I appreciated the moderators for giving me a little extra time to muddle my way through these pathways. But long story short, Venetoclax appears to repair immune function, basically, in multiple different subtypes of the immune system. So specifically, we noticed that there were changes in lipid metabolism. We noticed there were changes in T cell activation and proliferation signals. We noticed that there was enhanced NK cell adhesion and function. We noticed that the T cells that we looked at were more stem-like, we call it, or able to proliferate and kill more readily and more frequently, basically. That's a hot topic in immunotherapy, particularly in the CAR T cell world, is how fit are those T cells to go do their business? How many targets can they go destroy, and keep doing their thing before becoming exhausted, right? And so our studies basically showed that Venetoclax treatment, certainly recognizing the effect that we're killing CLL, period, just the debulking, but this was an adjusted model trying to take into account treatment effects, shows that Venetoclax repairs the immune system in multiple different ways. And we see this as having some broader implications in treatment, basically partnering Venetoclax with other immunotherapies and cellular therapies, where you need healthier T cells to go about their business and killing the cancer. And so we're very, very excited. We've got a couple collaborations in the pipeline already, some clinical trials in development, and of course, some confirmatory studies to really nail down how this truly works at the molecular level.
Amazing. It's really exciting results. So thanks so much for explaining them.
My pleasure.
So I guess any other key takeaways from this research that you'd like to share with our audience, or anything they should know?
So I think first and foremost, the thing I'm most proud of, number one, is where I work. our patients, they had to donate extra tubes of blood, right? They had to consent to have their information. It's all secured, but it takes a special kind of person to have not only cancer or get treatment, but then also donate, to research projects. So I can't thank our patients enough and our support teams here at Roswell. That's number one. I just want to acknowledge that we can't do any of this stuff without consent from our patients. The second thing I'd like to leave is that, I think our approach, looking at off-target effects of drugs in a very sophisticated, multiomic molecular model, using bioinformatics, eventually using artificial intelligence once we get, large enough patient specimens to justify, some of our signals we're finding, will enable, I think, more sophisticated ways to predict not only treatment response, so, next generation prognostication. So we actually are looking at all of our clinical databases with all the pathology and molecular data. You can do advanced, imaging analysis even with AI now, right? With all of these results and link them together. And when you have enough patients with enough, time on, follow-up, we think that this might be the most sophisticated way to predict outcome in advance, potentially predict toxicity in advance. Ultimately, with enough funding, enough dedication, enough patience, and going through all these crazy pathways that we have to encounter and messy data occasionally, I envision this approach with obviously significant drug and cell therapy development as leading to more cures for more types of cancer. And I know I don't take that lightly, but I think that big data and sophisticated approaches like this are going to be needed to improve outcomes for some of our toughest to treat cancers right now. And CLL happens to be an easy thing to sample. These are T cells and malignant cells in circulation. And so, a blood draw is much easier than, say, serial biopsies. And so it's a really good model, I think, to look at this approach and validate this approach, but likely will be generalizable, looking at, pre and post treatment effects, and, correlated with response and toxicities, and basically ways to find better combination treatments that, rationally, you have actually a biological rationale that, these T cells are more fit, the disease is under better control. You could even maybe predict certain, drug metabolism you might actually find in our genetics, right? So who might be more sensitive to a given treatment than others. It's unlocking an entire new field of research that we're really excited and stoked to be on the cutting edge of. And I guess I would just say that, it's worthy of, number one, validation, but also looking at other disease states, other treatments, more time and follow-up. And with enough, collaboration and dedication, I do think this approach could lead to much bigger and better things in all of oncology.
That's so exciting, and definitely look forward to hearing more about this research as the field progresses. So as I wrap up today, my last question for you is one that we're asking every interview we have for ASH this year, is if a patient asks how this research might affect their care, either now or in the future, what would you tell them?
Number one, I would say stay informed, ask questions, challenge your providers, right, for answers. Most of the time we're going to say we don't know, or there's not enough data, which is true. So this is very, preliminary as far as results are concerned. I have the privilege of serving on our national guidelines for CLL. We do talk about immune function. We do talk about the significance of certain mutations and molecular features. The truth of the matter is a lot of these tests are new. A lot of our treatments are new. And we don't have enough, truly, we don't have enough data yet, reliable data to inform our decisions. And so, this is going to be a continuously adapting and evolving and improving field over time. And so I would say stay plugged in, stay attuned. Just know that there's these sophisticated molecular tests that are available in the research setting, and we're working to make them, easy to do in clinic, eventually validated and actually usable by doctors around the country with meaningful results. But it's going to take some time. I guess I would kind of leave it at that. But we're working on trying to predict infection risk beyond just simply looking at your IgG level or disease bulk or things like that. Like secondary cancer risk. There's a lot that's coming quickly. Things like liquid biopsies. Looking for cancer-related neoantigens and blood tests for cancer screening. Those things are coming. But again, it's rapidly evolving, but not yet validated quite yet in most settings. So I would say just stay tuned and keep checking in every once in a while with your local care team.
Great. It's a great message to share and to know that these things are coming down the pipeline. So thank you so much, Dr. Cortese, for coming on today to tell us all about this research. It was so exciting to hear about, and we look forward to hearing more about it in the future as well.
Thank you so much for having me. I appreciate you.